After the hour. A warm welcome, everyone, to today's BLN open discussion on the introduction of the COVID-19 vaccine with lessons from Liberia. A very special welcome to the discussion moderator and our guest speaker. I am Catherine Muyawala, the Bid Learning Network Coordinator, as your host. And as many of you know, the Bid Learning Network is a peer learning platform led by PATH. And this is the second webinar that we have in a three-part series about the experiences and lessons learned from the COVID-19 vaccine introduction from Africa. These interactions are actually intended to promote mutual learning among the public, private, and international healthcare practitioners, policymakers, program implementers, researchers, academia, but to name a few. So before we begin with the business of the day, I would like to quickly remind us all about the ground rules. In the chat box, would really appreciate if you could type in your name and the country where you're connecting from. And if you're sharing the same connection as your colleagues, would appreciate if you just added the number of the other persons who are joining you in the same connection. We expect all participants to be muted and their videos to be disabled. Of course, this is to allow the discussants or the speakers to speak without interruption, and also to see if we can minimize on affecting the bandwidth for those with low internet connectivity. There will be a question and answer session at the end of the discussion. And if you've got any questions, burning questions, in case you don't want to lose your train of thought, you're encouraged to submit the questions in the chat box. They will be logged and answered during the question and answer session. And also just to mention that this webinar is being recorded and that the link to the recording will be shared later on through the Google Groups and the BID website. Back to our webinar topic on the introduction of the COVID vaccine in Africa. We know that the pandemic has taken the world by storm. It has disrupted health services, increased morbidities and mortalities, and it has generally thrown socioeconomic systems into disarray. And according to the World Health Organization, globally, the pandemic has claimed close to 3.5 million lives and has more than 167 million people infected, and we have about 5.5 billion vaccine doses that have been administered. And we give a special thank you to WHO, UNICEF, and Gavi, the Vaccine Alliance, and many other partners who have tirelessly supported countries around the world, including 47 African countries, to access these vaccines. And we know that the vaccine supplies to Africa began as early as February 2021, and most of them are now deploying the vaccines. Last month, for those of you who joined us, we heard from Cameroon, who shared their experience with the introduction of the COVID vaccine. Today, we get to hear from Liberia on what the experience has been as well. So to lead today's discussion, we are honored to have Mr. Dominic Kwabina Atwim. He's the BLNP advisor from Ghana. Dominic has got close to 20 years experience in health information systems and e-health implementation. He's currently working with the Policy and Planning, Monitoring and Evaluation Division of the Ghana Health Service as Innovation and Technology Lead for the implementation of the Ghana Health Service Information Exchange. He oversees the development, deployment, and implementation of district health information management systems in all the 216 districts in Ghana that built on the DIHS2 platform. And additionally, Dominic is a technical advisor for the Ghana Health Service e-health system interoperability with the DHMS2. Dominic also has been spearheading the deployment of the e-tracker for the maternal and child health service, including immunization, growth promotion, TB client screening, care and treatment tracking. He's been working on early infant diagnosis tracking and HIV treatment for all antiretroviral therapy centers in Ghana. He also served as a focal point person for the Global Fund Against HIV and AIDS, TB and Malaria 2017, data strengthening support to Ghana. He is the technical lead for Ghana Health Service on improving digitization in Ghana civil registration and vital statistics on birth and death data. A warm welcome to you once again, Dominic, and of course to our speaker from Liberia, Mr. Adolphus Chokon-Clark. I will now hand over the floor to the moderator just to introduce our distinguished speaker and lead us through the discussion. Dominic, over to you.
Thank you, Catherine, for that introduction. And we welcome on behalf of PATH and all the others on this platform. We welcome you all for this important webinar. The speaker for today is called Dr. Adolphus Chokon-Clark from Liberia. Adolphus Chokon-Clark has more than 7 years experience in the coordination and management of the EPI program called Expanded Program for Immunization, and has served the Ministry of Health in Liberia since 2009. His current position is the EPI manager, and his key responsibilities span the control of all aspects of the EPI activities. He's responsible for the planning, coordination, and management of immunization program, including routine and supplementary immunization activities, health communication, surveillance, monitoring, evaluation of EPI information. And I'm sure you understand his current predicament with the current vaccination going around in terms of COVID. During his career, Adolphus has made significant contribution to science through research and has published numerous articles on immunization, Ebola, and COVID-19 pandemics. He has led and coordinated the introduction of various vaccines in Liberia, notably the IPV, Rota, HPV, and MCV2, among others. He holds a Bachelor of Science degree in Pharmacy, Chemistry, BSc, and Masters in Public Health, obtained from the University of Liberia and the Continental University Graduate School, respectively. He also holds a postgraduate diploma in health system management, as well as a certificate in EPI leadership and management. He's currently a PhD candidate in the public health with Taxila American University. So at this point, I mean, I'm sure all of you will testify with me that, I mean, he's the right person and for him to give us this talk about this important topic, the introduction, the experience of Liberia, lesson learned from Liberia, the introduction of the COVID-19 vaccine. So welcome, Dr. Adolphus Chokon-Clark.
Thank you, Dominic. And let me say good afternoon, good morning, good evening to all, depending on your time zone. And nice to be on this webinar today. Thank you.
Thank you too, Adolphus. So we want to start a bit with how things have gone with Liberia. Yes, I'm from Ghana, so we may have similar systems and all that. So please tell us, how did Liberia arrive at a decision to introduce the COVID-19 vaccine? What happened? What did you guys go through for you to finally say that, hey, you're going to introduce this vaccine to the people of Liberia? Can you tell us a bit about that?
Thank you. I know that we are all testimonies globally to the consequences of the COVID-19 pandemic. We are testimonies, like I said, of the extent to which this disease has caused unbearable marks on not just the lives of people, but economy and every fabric of the economy. So it all started in Liberia, September 18, 2020, when we received from the COVAX facility an official communication notifying His Excellency, the President, His Excellency, Dr. Weah, that we had 3 opportunities under the Official Development Assistance, the ODA, covering 3 technical areas. The first looks at vaccine procurement, the second talks about coaching expansion, and then the third looks at technical assistance to be able to achieve the first 2 components. So through his office, the Honorable Minister of Health was notified that she needed to take action, and said communication was then sent to my office to look through and advise her on how to proceed. And so from that point, we were able to constitute a COVID-19 vaccination pilot, bring on board all of the immunization actors in country at the time, and also colleagues that had time to join from outside Liberia virtually, and this is the new normal that we are getting accustomed to. And we started the process on December 16, 2020. We made our official submission to the COVAX facility, expressing interest as a country to use out of the COVID vaccine that were been available, with a condition that we were very clear relative to the current coaching infrastructure in place. And so our preference as a country was more like skewed towards AstraZeneca, since at the time Johnson & Johnson had not gotten EU approval. So that's how it all started. And on January 29, 2021, we were officially communicated back to through the COVAX that our application has been accepted, and Liberia will receive her first shipment of 96,000 doses in March. And so on the 5th of March at 11:17 p.m., we received our first batch through the COVAX facility, where 96,000 doses arrived on Europe wing instead of SM Brussels. But our understanding is that Europe wing and SM Brussels, they are in some partnership. And so since we couldn't have the SM Brussels flight coming, it had to come on Eurowing. And of course, there had to be this ceremony taking place at the airport for the arrival of such an effective public health tool in combating this pandemic. So that's how the chronology of the entire process started in Liberia. And then on April 1 officially, we did our first inoculation as a country, where we were able to reach the first 138,000 persons. 130 persons rather. We were able to vaccinate the first 138 persons, of which we had 81 being male, and then we have 57 being female. So that's how the entire process commenced in Liberia.
Great. Thanks for that insightful, detailed information. Very loaded, and I think a lot of countries are part of this COVID initiative. Were you the first person to get inoculated or vaccinated, or was the president?
So I was the third on the line. The Honorable Minister of Health was the first, followed by the WHO country representative, and I was the third person. So I'm due for my second dose June 1.
Great, great. So let's talk a bit about the challenges. And the challenges, I want to talk much more on your preparedness, the vaccine delivery, financing, implementation, how you identify your targets, a key issue that keeps coming up, vaccine hesitancy due to misinformation. Then we'll talk a bit of data capture. So let's start with your preparedness. What are the challenges that Liberia has encountered in the introduction of the COVID-19 vaccine? One, in relation to preparedness.
So the way I will put it is that traditionally we are used to having in-person meeting if we are developing a technical document, be it a technical proposal or an application. We've been so accustomed to this in-person meeting and having to do an application where, one, you have to observe physical or social distancing, Two, at the time, you have some of your technical partners outside Liberia and they were teleworking, became a more challenging task, especially so time difference, having people working from home, sometimes to get that level of commitment without any distraction became something that was challenging during the preparatory stage. More so, we had to work tireless hours to ensure that as a country the deadline was achieved and reaching across the aisle to other relevant government institutions to be able to get all of the demographic information needed to inform that application was again a slow walking process, but it was good that we were able to get it through. For me, I don't see them as challenges. What I see opportunities, and what has been the most important thing for us as a country team, in my opinion, have been the way in which we're able to tap into those opportunities, how we're able to actualize them. And we went through it. The preparatory stage was interesting. You know, you used to seeing somebody and asking questions, and now the person is probably distant mile away from you.
Yeah.
I mean, yeah, and then sometimes the internet is not so friendly, and logging off, coming back on. I mean, it becomes so frustrating at a given point in time, and you're being reminded persistently about the time. So those are some of the challenges that we had to be able to prepare as a country. Because if you look at the technical guide, Gavi was also, or the COVAX facility were also very strict relative to the target groupings. They were very, very clear, and the technical guide came out of a very short point in time. Countries had to internalize it and know exactly how to birth or develop this application that they call the vaccine request application, the VRO for the COVID-19. So at that stage, yes, we had some challenges, but I think they were all opportunities because we had to adjust from what we're normally used to in terms of technical convergence, and have to play by the new rules, which is telework in virtual meetings. So those are some of the things that we had to do, because the Honorable Minister had assured His Excellency the President that Liberia was going to apply, because that was a golden opportunity. Even though the number of COVID cases in Liberia were very, very minimum, but we thought that as a country, we should be engaged in global efforts to ensure that the pandemic is brought under control, and just following all of the IPC measures that we know are not basically sufficient to end the pandemic. So we needed to be on board to have the vaccine brought in the country.
Great, Chokon. And I mean that is also very insightful, and we all appreciate the fact of all of us moving from in-person meetings to remote meetings. Sometimes you don't even get the feedback, but I like the point there of you talking about looking at those challenges and converting them into opportunities to work. Let's talk a bit about vaccine delivery, logistic, and cold chain. Did you have that pageantry, the press, media coming to the airports and everything? How did you finally get this vaccine to the service delivery point where the facilities have to start vaccinating those who need them? How did you do that?
So first thing, at the level of arrival, when the vaccine came on March 5th, 11:17 p.m., of course, there had to be a formal ceremony, and that brought together dignitaries in Liberia as well as media institutions or hosts to be able to cover the entire event. And so it went far and wide that Liberia's share of the COVID-19 vaccine had arrived in country. We had to work with our existing immunization infrastructure to be able to move the vaccine from the airport to the national vaccine store, and then subsequently deploy it across the entire country. But let me quickly say that when we were notified September 18 as a country, it was very clear that the COVAX facility was not going to provide any operational support. And so countries needed to either use the domestic resources or engage multilateral banking institutions as well as other donor partners to be able to mobilize operational costs for the vaccine deployment. And we are very grateful to the US government through the USAID that they were able to avail to Liberia 1.5 million for the first batch of the COVID-19 vaccine deployment in Liberia. This is something that we are forever grateful to them for. And as we write our immunization COVID history, we will be able to remember their support that they provided during the rollout process. So with that support, we had to work through our existing infrastructure. So we had to use all of our refrigerator vans, our dry storage truck, our logistic pickups at the county level, and our cold rooms to include the national and the regional cold rooms to be able to ensure that the vaccine integrity and potency are maintained at all point in time, given the relevant cold chain temperature. So these were things we had to do at national, regional, county, and up to the level of service delivery. So it was a difficult task because our deployment strategy had to be tweaked a little, especially owing to the fact that we had this issue of blood clot coming up. People became a little bit reluctant to come for the vaccine. And so we had to push it to them as opposed to the push system where they normally come with requisition, and then based on the requisition, we look at the consumption data and resupply. This time around, we had to use a push system where we had to take the vaccine to the last mile. So with that, we had a situation where we're adhering on our supply chain system, having the logistic working 24/7 to ensure that people within the target age group, they are fully vaccinated, but more so that the vaccine that reaches the last mile, they are in the right condition up to the point of administration.
Thank you, Doc. Can we expand a bit more on the vaccine hesitancy issue that you've just mentioned, or with regards to the push? The end user, I mean, those supposed to be vaccinated, or the service providers supposed to be giving the vaccine to them?
So if you ask me, I will tell you from the Liberia experience, it was bad direction from the get-go. When we had this issue of blood clot, even people, I mean, within the immunization infrastructure also were hesitant to receive the vaccine.
Yeah.
They are the ones to deliver the vaccine, and imagine if they are hesitant, then what more about the recipients? And so it was a very tough situation. I mean, it became a learning curve for us as a country. So we had to relook at our communication strategy. We felt that visibility or IEC SBCC materials were not going to address the concerns that people had. So we had to intensify our community engagement and our interpersonal communication. We needed to talk to people to hear them out. What were their concerns? If their concerns were linked to fear, what was that fear being expressed? And how we could use the available scientific information to address their concerns. So it became a very intense effort that we had to undertake as a program and as a country. Because like I said, when we did the launching ceremony, we were only able to reach 138 persons. But today, as of yesterday, our record shows that we've been able to vaccinate 55,690 persons. So you see from April 1 to current, we've made substantial progress, starting at as low as 138 to now being at 55,690. So we had to change our approach. We had to limit investment in visibility because people are not interested in seeing posters, flyers. People were more interested in talking to people expressing their concerns or bringing out their fear, and somebody being there to listen to them and helping to reassure them or helping them to rediscover their vaccine motivation. So it was a very intense process for us. We had to work from Monday to Sunday to be able to achieve it, especially so owing to the fact that the vaccine, the first batch of the COVID vaccine received through COVAX expires July 10, 2021. So just by looking at the start of the vaccination process in Liberia, where we were just able to reach 138%, and then when you tend to look at 96,000 doses, you get even more discouraged and say, how are we going to use this vaccine, or is it going to expire in our hands with all this disinformation about the vaccination? But we mustered the courage, and I like to say on the platform, hats off to the vaccinators, hats off to our colleagues in risk communication, community engagement, but most importantly, hats off to Liberians who show up after hearing us and once again believing in the vaccination program to receive the vaccine. I think they've been very fantastic, and owe them our great deal of gratitude, and look forward to see how our second dose administration goes.
Great. Adolphus, I mean, you mentioned something. Normally, communication styles are evaluated after a program, and then recommendation comes, and then you decide to change the approach. What did you guys do to quickly evaluate and think that, hey, flyers, posters are not going to work with your risk communication teams and all that? In the heat of the moment when things are happening, how did you manage that?
So when we started on April 1, the first thing I said to myself, prior to commencing, we already have this information about blood clots in Europe and other parts of the world. And so I have spoken to the Honorable Minister of Health and told her, say, look, Honorable Minister, this is not going to be an easy ride. We need to move outside of our comfort zone. We need to go into the communities and just talk to people as ordinary Liberians and just hear how they are feeling or how they think about this vaccine. No need of going through a structural process to say you want to do a survey, be a vaccine perception study, because you don't have that luxury of time. The vaccine already arrived and we started inoculation. So let us all just go into the communities and see how people are thinking. And true to that, we realized that when we move into the communities in Montserrat County, over 50 persons we talked to, all of them said, look, we're not interested in flyers. The first thing, the vaccine you guys brought, your brother to kill us. That's the first thing. So your flyers, your talk show, your leader, we don't want to see them. Don't put it on my house. Don't put it on my institution. So we started to get those kind of feedback. And I told her, I said, Madam Minister, if we invest in flyers and posters, banners, or talk show, it's not going to solve our problem because people have got fears. The flyers and posters is not going to convince somebody that you're not going to get.
Can you hear me, Trokon?
Yeah.
Hello.
I'm hearing you. Hello.
Hello.
Yes, I'm hearing you.
Yes, we can hear you, Dominic.
We can hear you.
Can you hear me, Trokon?
Yes, I'm hearing you. Yes, I'm hearing you. I'm hearing you.
Yes, we can hear you. Dominic, we can hear you.
Hello, Dominic.
I think he'll join us again. I don't know if he's dropped, but maybe you can continue.
Adolphus, just continue.
Just continue. He'll join us.
Yes. So I mean, so those were some of the harsh the harsh approach that we had to use outside of a more structured process in terms of doing other vaccine and perception survey using mobile phones or monkey survey, we felt that we didn't have that time. Already people had their own negative perception, and even doing a survey, they may be unresponsive. So we had to move into the communities, interact with people, and hear what they think. And when we realized that of the number of persons talked to, most of them had expressed fear as the main reasons why they won't take the vaccine. Then I told her, Honorable Minister, our risk communication and community engagement team, we have to change their approach. We have to intensify community engagement and interpersonal communication because people are not interested in flyers and posters. Investing in them now may not solve our problem. And graciously.
Hello, Catherine. I'm not sure if it's from my end or from that end.
Hello, can I continue?
Yes, please.
Yes,
Dominic,
so
Adolphus is still on the floor. Thank you. You can proceed, Adolphus.
Yes, so like I was saying, so on that note, we were asked to do a presentation at the Incident Management System meeting, the IMS. And when we made a presentation, the IMS members also saw the need that we needed to be more into engagements rather than flyers, leaflet, and they gave their blessings. And that led us to intensify our community engagement efforts, where we had teams moving out in the communities, holding town hall meetings, holding one-on-one meetings, holding small group meetings to be able to convince people, explain to them why they needed to be vaccinated and what are the benefits associated with being vaccinated, and also what are the perceived risks. Over.
Thank you very much, Adolphus. It looks like the moderator has dropped, but I think that's really, really fascinating, and I like the turnaround time that you made for communication on, the risk communication. But I think let's talk more about data management. I think that's one of the issues that most countries have had like to deal with. How has it been like for you to, to manage the data and disseminate it in terms of the vaccine implementation, for instance, health facility reporting and synchronizing of the data with other stakeholders? How were you able to do that?
Yes, so currently we are collecting data through our Google Sheet. What we try to do is to create a Google Sheet that people can do entry using the Google Sheet, and also we share with them Excel spreadsheet based on the WHO reporting template that was sent to countries. So we are using the WHO reporting template, but what we've done, we gave them the Excel template as well as the Google Sheet to be able to share the report in a more interactive and live manner, that you don't have to wait for total entry before you see what is happening. Once you have access to the Google Sheet and there is online entry, you see the numbers changing by the hours and subsequently by the day. So that's how we thought to approach the entire reporting process. Now, the other thing that we thought to do in terms of ensuring consistency was to come up with our COVID vaccination cards that we developed, so that all of the vaccinees or vaccine recipient, we have a uniform vaccination card that will be used across the entire country. So that was put in place. Then we had a monitoring team in the field to do what we call top-up vaccination. And the essence of the top-up vaccination exercise was to achieve a couple of things. The first thing is that to ensure that facilities are not overstocked because those facilities being used already have their existing routine immunization supplies. So we try to avoid overstocking at the level of those facilities, but more so, it provides an opportunity for the supply team to provide mentorship and or coaching where the vaccinator or the vaccination team has got some deficiency. And then lastly, they were charged with the responsibility of trying to collect the hard copy of the Excel-based sheet. So that way they are able to harmonize and reconcile the data being collected and reported. So if there were errors, they are able to detect the error in time and instigate the appropriate action.
Okay, sorry, I dropped up, so I just have to continue. Thanks, Catherine, for continuing for me. So a bit more on the data issue. How was the data captured at the during the vaccination? You've talked about a bit more on the COVID one, but if you could elaborate a bit more on how during the vaccination, how this data was captured down there at the facility level, and how this data get fed into before it gets to your table and for you to feed it back to the ministry for the decisions to be taken upon. Yeah.
So at the level of the health facility, we use registers or ledgers, and then we use daily summary books based on what WHO has shared with the Liberia team or the country team within the WHO region. So it is that reporting and collection instrument that we use to be able to collect the COVID vaccination data from the facility up to the district, county, and then we'll get it from the county in two categories. We'll get it through the Excel template that the county charge of our focal person sends, but we'll also get it on the Google Sheet. So all of the counties will send a link with the Google Sheet that you can do entry. So we also see what's happening in terms of performance. So from the level of the health facility, they use the paper base, that would be the ledger and the daily summary. And then when it gets to the county, they use the Google Sheet and also send us the Excel version, where we try to reconcile to see what has been inputted on the Google Sheet, whether it's still consistent with the Excel sheet sent. But we encourage across the country that the team that was responsible to do the type of exercise consists of people from the data management team, so that as part of their responsibilities would be to harmonize and review the data being submitted. So if there are any errors, they are able to correct those errors.
Oh, great. Any integration with other stakeholders like port of entries, the laboratories in terms of even cases coming in or knowing those who have it, and laboratory tests and all that, the standard authority, those who have to give you the clearance for the vaccines to be used and all that. How do you work with these people to ensure that you are all on the same page?
Yeah, so from the get-go, we work with all of the actors mentioned, the regulatory authority, our colleagues in the laboratory setup, or the National Reference Laboratory of Liberia. We work with all of the people to ensure that the relevant information were gotten. Remember, as part of our vaccine request preparation, there are sections that were specific to regulations. Owing to the fact that the vaccine being used is used on any issue emergency use listing procedure or the emergency use authorization, country's regulatory authority or the national regulatory authority had to give waiver. And in order for our Liberia Medicine and Health Product Regulatory Authority to give waiver, they had to form part of the technical working group to understand all of the technical details of the application process. And once that was concluded, the Honorable Minister of Health had to do a formal letter to the head of the regulatory authority for waiver. So the vaccine arrival in Liberia was contingent upon not just our official request that we submitted to have the vaccine brought in country, but also regulatory approval that said vaccine can be used in Liberia. So those are some of the things. And we also had to get information from the laboratory to inform that entire application process, as well as from the surveillance angle, because we had to pull together all of the numbers that we were seeing in Liberia. But more besides, what we've tried to do over the last 2 weeks is to strengthen integration as we do the COVID vaccine. So what we've been doing in few big counties is that before you are vaccinated, we do voluntary testing. We counsel you, look, you're not on a force, or it's not mandatory that you be tested before you receive the vaccine, but it's just good enough since we are using the RDT. You can just go do your test and know if you are negative, just take a vaccine. I mean, that further gives you the level of confidence and also helps you in your guiding decision relative to prevention. So we've seen this happening in 4 counties now, as part of our approach towards integration as we administer the vaccine. So we've been talking with colleagues from case management and laboratory to see how we could try this.
Okay, so Trokon, can you hear me? Yeah.
Yes, please.
Hello.
Hello, I'm hearing you.
Adolphus.
Hello. Hello. Yes, Adolphus. I'm hearing you. Hello, I'm hearing you.
Dominic, we can hear you. Okay. Thank you very much, Adolphus. It looks like Dominic has got connectivity challenges once again. Maybe just to continue the discussion as we're running out of time. And I think you have touched on most of the challenges, and for some of them you've mentioned the strategies. In fact, for most of them you've spoken about the strategies that you put in place to mitigate against those challenges. Is there anything else that you wish to add to the strategies that you put in place for those challenges that you mentioned?
So, if you ask me the caution that I would like to put on that, let us remember that as we turn to roll out or deploy the COVID-19 vaccine or any vaccination for that matter, let us move outside the box of one size fits all, because situation will differ from time to time. And so you should be more responsive given the current context in adjusting, or what I would refer to as aligning and realigning of the strategies. Because if you just have this mindset of one size fits all, then sometimes you may not succeed. So this is our own experience that we've seen, that as much as a strategy globally may be sent to you as a country as possible strategy to use, you should always look at your context and try to gauge your strategy based on the current context.
Thank you, Catherine, for stepping in again for me. In concluding, before we let our participants also ask their question, what lessons will you tell us? Can you give to all of us? I mean, other countries, and lessons that we can take home, or what to do, what not to do. Any key lessons that you can give us in relation to what we've discussed so far?
So what I've learned from this entire COVID vaccination exercise is, as a manager, as a leader, you should be more a listener than a talker. And like I told the Honorable Minister, people have expressed initial fear from the get-go. Those fears were legitimate. We needed to listen to them. After which, we tried to provide the facts. An attempt to discount them, or maybe bring them as anti-vaccine lobbyists may not be a good route to apply. I think they have their concerns, and we should be on an obligation at any given point in time to listen to them and provide the facts. This is one lesson that I've learned in Liberia, because if we had just assumed that these were all anti-vaccine lobbyists, because some of them had negative views that they even showed during this town hall engagement, that will permeate Liberia for a long point in time. So it's good to play more active listening role and talk less, because that helps in giving you a better sense of the extent to which a particular situation is and how you can strategize to address the situation.
Thank you very much, Adolphus. I think the key points that you've given us is that we should always listen and listen and listen very, especially those taking the lead in implementing this all important interventions when it comes to the COVID-19 pandemic. Now we'll open we'll open up for questions. You can raise up your hand and we'll call you in or you can type your questions in the chat box and we'll call you. All right, so we have Hassan Matinga, and then we have Dr. Puta too as well. So maybe we'll start with Hassan, please.
Yeah, thank you very much, Dominic and Adolf. My question is regarding to the service delivery, and apology if I missed this discussion as I joined a bit late. In terms of the vaccination process, were you integrating the COVID vaccine with the other vaccine, like the under one vaccine? There were, in terms of the facility, the cold chain, the processes, or you had to arrange for separate facilities and special care workers who would provide the COVID vaccine? Yeah.
Okay, so that is the first question. Maybe let's take the second one and then we'll like Adolfo's answer to them. So Dr. Puta, please, go ahead.
Yeah, thank you. I just wondered, Adolphus, congratulations, by the way, first of all. I think you did a good job in Liberia because you listened. But my question was, having reassured people and having gained their confidence, have you actually had any concerning adverse events as a result of the vaccine?
Good. So Adolphus, two questions. Whether the vaccine was integrated, and then go ahead.
Yeah, so I will start with the last question or concern, and then I go gravitate towards the first. So relative to AEFI or AESR, what we've seen in Liberia so far has been those ones that are non-serious, so to speak, and we've tried as much as possible to intensify our safety monitoring. So I just give you a list of some of the feedback that we've gotten from vaccinees or vaccine recipients based on the AEFI reporting form. So we have more people reporting fever and headache. We have fewer people talking about nauseation. And then we have fewer people also talking about body pain, and then fewer people talking about having dizziness or diarrhea. So otherwise, we don't have any serious AEFI as a country. I mean, we try to intensify and further strengthen our safety monitoring system to ensure that we don't miss out on any case, whether it is non-serious, serious, or a case that could lead to disability or death. We want to be sure that our safety monitoring system is very responsive to pick up any case. But at this point in time, all we've seen, they've all been non-serious, and I think that has helped in allaying some of the fears that people had relative to thrombosis or thrombocytopenia or whatever that we've seen that have been reported from some European countries. So far so good. This is what our safety data is telling us. We continue to monitor and see what comes out of that. The first concern that talks about integration, yes, of course, we don't have the number of coaching infrastructure to run a parallel coaching system for COVID. So yes, the COVID-19 vaccine is integrated into the bigger immunization supply chain system, be it at the national, regional, county, and health facility level. What we're trying to do is to ensure that there is clear distinction and demarcation so that we don't miss out on. And the people who are providing the COVID vaccination services are basically different from those who are providing routine vaccination services. Over.
Okay, thank you for that explanation. If I may follow up on what Hassan said, I mean, so what you are saying is that, is it the case that the current COVID vaccine, so for instance, if you pick the normal vaccination regime of Liberia, you may have your up to 6 plus 10 different vaccine in their vaccination book. I think what he was trying to find out is whether this is now part of the normal vaccination that goes on, or this is just for a one-off thing like we do with EPI as a campaign, we do with polio or a measles mass campaign. So if you can clarify that a bit.
Yeah, but we all know that at this point in time, we've not gotten global guidance yet.
Yeah.
Whether the COVID-19 will be integrated into routine vaccination or whether it will be used as a response intervention. At this point in time, I think what many countries are using the vaccine for is to respond to the current pandemic. There isn't a clear guidance on whether this vaccine will be officially integrated into countries' national vaccination policy moving forward. Remember that the vaccine has not been pre-qualified yet, but the extent or the magnitude of the pandemic, countries were on that moral obligation in an attempt or in a quest to protect the lives of citizens to ensure that this public health tool could be used on an emergency use listing, a procedure, even though it has not been pre-qualified.
Great. Thanks for that clarification. So we'll take further questions, maybe 2 or 3 more, and then we'll hand over to the secretary.
Moderator, I'm not sure if Hassan forgot to bring his hand down, or anyway, he's got his hand up.
I think it's the old one. It's the old one. It's not. All right.
Oh, okay.
Thank you, Adolf. I think also on the data systems, are you using any electronic system, or you're still for COVID vaccine? And what is your experience on that? If you are.
So we are having ongoing conversation. We've had 2 meetings now with the developer and intend to digitize the COVID-19 registration and reporting process. We've had 2 meetings. The first demo was presented, then we made input at the technical level. We had a second meeting where a modified version was presented, and we made another input. And our timeline is to ensure that by the second week of next month, latest the end of next month, we will be going digital. We will be digitizing the entire registration and reporting process. But at this point in time, like I said, we have more like a hybrid approach towards the entire process, where at the level of the health facility, we are still using paper-based report. And then when you get at the, we use the Google Sheet and electronic means to report. Over.
Okay, thank you, Adolphus, for that clarity on that area. I think we have a message in the chat box. No. Okay. All right. So I think at this point, thank you very much, Adolphus, for that insightful, detailed information. You've really given us a detailed activity by activity line inside of what happened in Liberia, and I've really learned a lot, especially the aspects of how you manage to work on moving from in-person meetings to digital meetings, where you don't even get feedback. You don't even really get instant feedback, and you don't know whether you are reaching people, but you manage to use that. And the other aspect of the pull and push with your risk communication within an implementation period where no real evaluation has been done, but you were able to see that there were certain gaps when it comes to letting people understand the importance of the vaccine, and identifying that you just don't have to send posters there or do media noises and think people will read them, but a bit more of getting in touch with the community. So that community entry, community communication is a key thing. And also, you talked about listening, and I think that is a key lesson, that key leaders who lead when it comes to certain key interventions, especially with what we're doing in the sub-region, managers and stakeholders need to listen. So on behalf of the PATH and all my friends and colleagues on this platform, I thank you. And as a moderator, I hand over to Catherine. Catherine, please take over.
Thank you very much, Dominic. Very well driven and very well summarized. And to the audience, I'm sure you heard for yourself the lessons that are coming from Liberia. So now that we've come to the end of the webinar, I'd like to thank you all for joining us today in this engaging discussion. A very big thank you once again to you, moderator, Dominic, and very special gratitude to Adolphus Clark for sharing and elaborating Liberia's experience with the vaccine introduction. Just to remind everyone, this webinar has been recorded and will be shared in due course. And also just to encourage you to continue connecting with us and engaging in discussions with the BLN through the discussion groups. And we're also appealing to you to follow the social media platforms such as Twitter and the rest that are shown on the screen. And you can also read more about what's happening in the network on our website, blogs. Please join us again next month when we get to hear from Malawi and the experience with the COVID-19 vaccine. So with that being said, I'd like to implore all of you to please keep safe from COVID-19, continue observing social distancing, masking up, and remember to wash and sanitize your hands frequently. If you haven't been for the vaccine, which are probably at your disposal and you haven't made use of them, please do that. I went. Till next time, bye.
Thank you, bye.
Thank you, bye-bye.
Thank you, bye.
So much, everyone. Until next time.